A pleasant day, dear doctors, and welcome to our intensive blitz under cardiology, so under the subspecialty of cardiology, where I will be covering internal medicine in a masterclass format, and I will specifically be inserting some very die-hard, high-yield pathology, most especially when we talk about the pathogenesis and the clinical manifestations of these diseases. So this is Dr. Toom. Good day and welcome to our session. So let's start the ball rolling. This is the course outline of the first part of the cardiology module, and I should be able to cover the following important high-yield diseases. So first is going to be rheumatic fever. Then we have infective endocarditis, cardiomyopathy, endocarditis, the pericardial diseases, and lastly, the cardiac tumors. Now, these are the specific cardiac diseases which you should take with you to your respective board exams. Let it be the physician's licensure exam or the Philippine Specialty Board of Internal Medicine written exam. Now, these are the following references I'll be using. The gist of the talk is going to be from Harrison's 21st edition with some very important correlative tidbits from the 10th edition of Robbins and Cotran Pathologic Basis of Disease. Now, I'm not sure if you're aware of this, but a lot of the authors of Robbins Pathologic Basis of Disease under the unit of cardiology are actually the same authors in Harrison's. Now let's begin with the first disease, which is actually rheumatic fever. Now let's start stimulating your brain cells. When you hear the words rheumatic fever, is this generally a disease of the rich or a disease associated with poverty? Is it a disease generally associated with poverty, or is it a disease associated with the rich? Okay, good. In the epidemiology and prevalence of rheumatic fever, it's actually associated with poverty. It's associated with overpopulation. It's associated with overcrowding. Now, what is the first bacteria or organism that pops into your head or should pop into your head when you hear rheumatic fever? What is the first organism that should pop into your head? Okay, very good. I agree. It should be Streptococcus pyogenes. Okay, now Streptococcus pyogenes is what group of streptococci based on Lansfield's classification for Streptococcus. This is classified as group A. And what about the hemolysis pattern? What is the hemolysis pattern of Streptococcus pyogenes? Is it alpha hemolysis or is it beta hemolysis? So this is beta hemolysis. And don't forget, beta hemolysis is what? Is it complete or incomplete hemolysis? What is beta hemolysis? Okay, so what is alpha hemolysis? What is alpha? Okay, partial, incomplete. What is alpha? Okay, you have complete. So this is group A. This is commonly known as group A beta hemolytic streptococci, or commonly known as GABHS. So complete hemolysis is alpha. Then you have beta, which is partial hemolysis. Now, this is most likely going to come out in your exam. What is the most common antecedent event or the most common antecedent infection which is associated with rheumatic fever? It's a group A, streptococcal pharyngitis. Okay, so this is strep pyogenes. Now, this is usually seen in the age groups of 5 to 15. Therefore, you should see it in the pediatric age group. The patients we see who are adults are usually patients with long-standing rheumatic fever who now develop cardiac complications, and that is what we call rheumatic heart disease. So this is the age group which is most common. Okay, so we have 5 to 15. Now, there is a very important figure found in your textbook. It shows to you the exposure to the group A streptococci, so that is the initiating event. This can either be an upper respiratory tract infection, URTI, particularly pharyngitis, okay, or tonsillopharyngitis. So please take note of that. So the respiratory tract infection, which you will most likely encounter, is going to be tonsillopharyngitis or streptococcal pharyngitis. Now, a sequelae of this untreated, I'd like to put the word untreated, streptococcal infection is now associated with ARF, or acute rheumatic fever. Now, do not confuse this with acute renal failure, okay? Now, if this rheumatic fever is untreated or it's recurrent, this can lead to rheumatic heart disease. Rheumatic heart disease has a handful of complications. In this figure, it shows you there's heart failure, stroke or endocarditis, surgery, disability, and death. Now, question. What is the histologic hallmark? Histologic hallmark, so microscopic, okay? The histologic hallmark of rheumatic fever. Okay, very good. It's the Askoff bodies. Okay, the Askoff bodies. Now, question. If the histologic hallmark of rheumatic fever are the Askoff bodies, what do we call the caterpillar cells or the histiocytes in the heart? Okay, they call them the caterpillar cells or the cardiac. Okay, we call them the cardiac. I'm just going to draw a heart here. The cardiac histiocytes. Okay, the cardiac histiocytes or the caterpillar cells. These are known as the Anitskow cells. Now, if you notice, Anitskow and Askoff, they are Russians. What are they? Look, RH. That's for rheumatic heart. They are Russians. What's their nationality? Mga Russian. Da. Okay, Anitskow and Askoff. So please take note of that. Okay, Anitskow and Askoff. So a very important figure. Now, let's go to the pathogenesis, which is actually a generalized immune response. So this is the famous molecular mimicry. So what happens here is there is a specific immune response which is targeted specifically to the streptococcal antigens. And this targets the M protein as well as the carbohydrate and acetylglucosamine of the group A streptococcal carbohydrate. Now, can you give me other diseases that presents with molecular mimicry? In fact, you just discussed one yesterday. What neurologic disease okay, would have as part of his pathogenesis molecular mimicry. Okay, that is multiple sclerosis. Okay, very good. Multiple sclerosis. So take note of that pathogenesis. Now, here's a very nice figure from our textbook. These are what we call vegetations. They are found in the heart valves, okay, usually in the heart valves. Then here, pointed arrows, okay, right here, these are your Ascough bodies. Now, this is the mitral valve. If you notice, there is severe stenosis. What is the description? What is the description of the mitral valve when there is severe mitral valve stenosis? Okay, very good. It's the fish mouth orifice. And what is the usual size for it to reach a fish mouth orifice? This is very important because this is already going to be an indication for surgery or valve repair. Okay, so the magic number, fish mouth, okay, is it 1 or is it less than 1? Okay, is it 1 cm or less than 1 cm? Okay, it is less than 1 cm. So once the fish mouth orifice is there, that is already indicative that most likely that valve is less than 1 cm. Now, this is very important because this is lifted from the morphology of Harrison's, which has to be correlated with, this is from Robbins rather, and it has to be correlated with Harrison's. So here is the Ascough bodies, okay? Then we have the Anitskau cells, which are actually going to be macrophages, okay? Now question, where would we find the heart failure cells? Where would we find the heart failure cells? Okay, very good. We find them in the lungs. We do not find them in the heart. Okay, very good. So here we have in bold letters the Ascough bodies. Then we have the Anitskau cells. Okay, then we have here the caterpillar cells. Okay, now I want everyone to remember, okay, these irregular thickenings, these subendocardial irregular thickenings. These are called the McCallum plaques. Okay, so 3 eponyms. We have Anitskau's bodies, Anitskau cells, the Ascough bodies, and the McCallum plaques. These all point to rheumatic fever. Then, of course, we have the verrucae, which are actually the vegetations. Now, you have to remember the vegetations are actually comprised of multiple components. It's comprised of fibrin, a fibrin clot, debris, cellular debris. It's also comprised of bacteria. So these vegetations are a perfect nidus for infection. What do we call that infection of the heart, which is associated with vegetations? Okay, what do we call that famous infection of the heart, which is associated with vegetations? Okay, so we have infective endocarditis. Okay, we have infective endocarditis, which we'll be talking about after this. Okay. Now, I want everyone to be familiar with a specific endocarditis, which is seen in lupus, okay, systemic lupus erythematosus. And this is the Liebman-Sachs endocarditis. So Liebman-Sachs endocarditis is seen in lupus. Now, question. Okay. Lupus or SLE has different types of nephritis. The most common type is the type 4 or the diffuse proliferative. What are the classic microscopic lesions we see in the kidney of lupus nephritis? Okay, this is going to come out. Lupus nephritis, what is the classic finding in the kidney? Lupus nephritis. So for example, if diabetic nephropathy has the Kimmel-style Wilson lesions, what lesions do we see in SLE, particularly the kidney? Okay, we see the wire loop. Okay, the wire loop appearance. So please take note of that, wire loop appearance. The wire loop. Okay, then we have what we call the non-bacterial thrombotic endocarditis. A non-bacterial thrombotic endocarditis. Okay, these also present with vegetations. Can anyone tell me what is the most common cancer which is associated with non-bacterial thrombotic endocarditis? This is associated with a malignancy. What is the malignancy? Okay, what is the malignancy which is associated with non-bacterial thrombotic endocarditis? What is the malignancy? Let's see your answers. Okay, what is the malignancy? Okay, the cancer. We're asking about the specific cancer. Okay. Yes, this is a form of morantic endocarditis. I'm asking for the cancer. What cancer is it? Okay. A mucin-releasing adenocarcinoma of what organ? There's two cancers, actually. One is from the lungs. Okay. That's the small cell. Okay, the lungs. Okay. The other is the adenocarcinoma of the colon and the pancreas. Okay. So dalawa yan, adenocarcinoma of the colon and the pancreas. But it's more commonly seen in the colon. Okay. Now, let's talk about rheumatic fever. Does anyone know what this criteria is called? The one that has 5 criteria. We have the polyarthritis, we have the chorea, the pancarditis, the erythema marginatum. Okay, this is known as the Jones criteria. Okay, this is known as the Jones criteria. The Jones criteria. Okay, Jones criteria. So please take note of this. So number 1, we have the migratory polyarthritis, usually affects the large joints such as the knees, okay, the elbows. Then we have a pancarditis, which can involve basically all layers of the heart, okay, myopericarditis, okay, endocarditis. Then we have the subcutaneous nodules. Then we have the erythema marginatum, and of course, Sydenham's chorea. Now, question, what is the major difference between Sydenham's chorea and Huntington's chorea based on pathogenesis. What is the major difference between Sydenham's chorea and Huntington's based on etiology? Okay, based on etiology, etiopathogenesis. So what causes Sydenham's and what causes Huntington's? What causes Sydenham's and what causes Huntington's? Okay, Huntington's is genetic. Okay, it is genetic. It is not drug induced. Huntington's is because of a trinucleotide repeat or a triplet repeat, particularly of CAG, 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 CAG. Okay, so it is genetic. While Sydenham's chorea, which we also call Saint Vitus dance, this is acquired because this is associated with rheumatic fever. So please take note of that difference. Now, the most common feature, the most common clinical feature, this is already one question in your exam, of rheumatic fever is polyarthritis. Carditis, which a lot of students might be tempted to answer, is only the second most common cause. The most common cause is, and the most common feature rather, not cause, the most common feature is going to be polyarthritis. Okay, most common feature is polyarthritis. So please take note of that. Okay, please take note of that. Very good. So I hope you got this. Now, the hallmark of rheumatic carditis is going to be the damage to the valves. So the valvular damage is the hallmark of rheumatic carditis. And the most common valve that is involved is the mitral valve. Question: what is the next valve which is involved after the mitral? Okay, mitral is number one. What is number two? What is number two? Okay, correct. It is the aortic valve. Okay, mitral valve is number one. Aortic valve is number two. Okay, aortic. Now, as to the joints, okay, because we mentioned polyarthritis is the most common. So it's a migratory type of polyarthritis, which means palipat-lipat siya, pabalin-balhin. Okay, transferring from one extremity to the other, from left to right. So it's asymmetric. In my experience of encountering rheumatic fever, both in training and actual practice, it's actually the arthritis, which is the presenting manifestation that we get. Now, what about the neurologic features of rheumatic fever? There's only one, and that is chorea. Now, this chorea is also known, as mentioned earlier, St. Vitus dance. So how do we differentiate this from Huntington's chorea? The etiology, Sydenham's and St. Vitus is acquired, while Huntington's is a genetic trinucleotide repeat disorder. Usually involves the basal ganglia. Next is the caudate nucleus. Now, chorea can present as a single manifestation of rheumatic fever. Now, in anticipation for the written exam in IM, I want you to be familiar with the treatment. Okay. What is the drug of choice for the treatment of chorea? Okay, what is the drug of choice for the treatment of chorea? This is the FDA approved drug, which is not available, unfortunately, in the Philippines. Okay. It's marketed as an antipsychotic. So it's tetrabenazine. Okay, we can use antipsychotics like risperidone. That's what we use in practice, or quetiapine. Haloperidol is still there, but we stay away from haloperidol. So take note. If tetrabenazine is not in the choices, then this is what we look for. Risperidone, quetiapine, or haloperidol. But again, haloperidol is discouraged. So please take note of this. Jot that down as well. Now, question. What is the drug which is used to treat Parkinson's disease, used to treat influenza, that can also be used to treat Huntington's disease? Okay. Very good. It's amantadine. Okay. Amantadine can also be used to treat chorea. Also used to treat chorea. Stretch while you can. We'll be taking a short break in a while. So for the skin manifestations, we have the classic rash, which is described as erythema marginatum. The exact words in the book: pink macules with clear, centrally spreading edges. So it's a macule. Now, question. What is the rash that we see in Lyme disease? Okay, this is, of course, caused by Borrelia burgdorferi. What is the rash? What do we call that target or bullseye rash? May pangalan yan. Target or bullseye. Okay, very good. It's erythema. Don't mix this up with erythema marginatum. This is erythema chronicum. Okay, migrants. So please write that down. Okay. So please take note of this. Now, next, this is how it looks. This is the erythema marginatum. Okay. Then, of course, we're going to talk about the nodules. Okay, they are actually painless. Okay, they are nodules which are mobile. They may present as lumps, okay, over the bony prominences or over the knuckles. They are painless, they are small, they are mobile lumps which are found, okay, beneath the skin, overlying the bony prominences. Now, what do we call the nodules? Let's try to play fill in the blanks, see how good your comprehension is. Okay, I'm asking for nodules in a female presenting with a violaceous rash on the eyelids, and she's complaining of muscle pain. Okay, so first, what's the diagnosis here? You need to level up your comprehension if you want to top the exam. So what is the condition? Okay, this is dermatomyositis. Very good. This is dermatomyositis. Okay, the violaceous rash, this is known as the heliotrope or the helicotrope rash. Okay, the nodules, what do we call the nodules? They're Gauthron's nodules. Okay, so I'm trying to go in a reverse manner wherein we're going to see whether you understand or not. Okay, no excuses. It's either you know or you don't know. So please take note of that. Okay, so jot this down. Okay, so let's clear this up. Now, let's go over some tables. This is lifted from your Harrisons. This is the famous, okay, this is the famous Jones criteria. Do you have to memorize the whole table? Yes or no? Do you have to memorize the whole table? My question is yes or no. Okay, the answer is a big no. Okay, you don't have to memorize. Now, I want everyone though, okay, to memorize this. This is what I want you to memorize. Two major manifestations, which is the major criteria is here, or one major plus two minor. Of the minor criteria, memorize the fever, memorize the ESR. You can forget about the CRP. Just memorize those two. Okay. Now, question. In what condition or scenario can you come up with the diagnosis of rheumatic fever with only one manifestation plus a history of a recent strep infection? Okay, what is that one condition? Okay, very good. If there is Sydenham's chorea. Chorea alone plus the background. Okay. Chorea alone plus in the background. Okay. chorea alone in the background of a recent streptococcal infection is enough to clinch the diagnosis. So please take note of that. So take note of what I boxed out. Okay, please take note. Take note of what I boxed out. Let me clear out. Now here's another table, which is actually an enlarged version. And this is what I want everyone to memorize. 2 major plus 1 minor. 2 major, okay, or 1 major plus 2 minor. I stand corrected. Now, lastly, what is the best treatment for rheumatic fever? It's going to be penicillin. Or treatment as well as prophylaxis. Okay, treatment and prophylaxis. Now, question. You are treating a patient with penicillin. Whether this is a case of syphilis or rheumatic fever, and all of a sudden, they develop rash, fever, okay? They develop chills, okay? Headache. What do we call this reaction? Okay, this is known as the Jarisch-Herxheimer. Jarisch-Herxheimer, right? Jarisch-Herxheimer reaction. Okay, so please take note of this, Jarisch-Herxheimer. So this basically ends our topic on rheumatic fever.